You're watching PCTV Channel 17, proudly serving the Port Clinton City School District community. The following is a production of the Port Clinton High School Digital Media class.
Welcome to Time for Health. I'm your host, Rachel Fall, and we're very glad you've joined us. We hope you gain something from the program that helps you and your loved ones. We want to arm everyone with as much information as possible so we can all make good choices. And this is not to take the place of regular medical care, so be sure to include your healthcare provider in on your plans and your conversations. And today, our guest is Dr. Greg Goings. Thank you for being here.
You're welcome.
You are an orthopedic surgeon.
Correct.
So you do bones, joints, things of that nature.
Muscles, tendons, right.
Okay. So primarily we're going to talk about joint replacement today.
Okay.
So when I think about joints, there's there's joints all over your body. What joints do you do, or what joints can be done? Like, can you replace a knuckle joint? Or
Almost any joint can be done, even joints in your spine.
Okay.
But I primarily do hips, knees, and shoulders.
Okay.
Can also do elbows, wrists. I do ankles too.
Okay.
But we don't see people very often who need those joints replaced.
And so there's a difference. I moonlight at the hospital as a social worker sometimes, and so I see people who have joint replacements, but then there's also other things you do, like can you fix ligaments or ACLS or?
We can. If you have a torn ligament or a torn tendon or anything like that,
okay,
that can be fixed as well.
Broken bones, dislocations,
absolutely.
all that kind of stuff.
All that stuff.
But sometimes the joints need to be replaced.
Correct.
They wore out.
Either that or they're broken in an injury,
okay,
and they won't heal right.
Okay, so they need to be replaced.
That's very rare, but yes.
Okay. What is it replaced with?
Well, it's resurfaced more than replaced.
Okay.
We don't really replace the bone or the muscle attachments or anything. We just replace the surface area, because what's happened is the surface is worn out,
okay,
and that causes pain.
Okay.
There's a layer of cartilage. It's kind of like Teflon that's normally on a joint surface,
okay,
and that slowly wears away over time in some people for genetic reasons. And after a while, the bone starts to rub on the bone when the cartilage wears off, and we just replace the cartilage.
Okay. It wears out, so wear and tear.
It just wears out.
And you said there's a genetic component too, like some people are prone to
in some people, yes,
wearing out faster than...
Right.
And then are there, jobs with repetitive movement or runners or that kind of stuff?
There's post-traumatic arthritis as well. Sometimes it is repetitive use of the same joint.
Okay.
Sometimes it's just a car accident or a fall from a height, and you just break your joint and it won't heal.
Okay. Do they replace it? Joint replacements, do they use mechanisms like metal parts and things like that? They
usually have a metal plate or metal cap that goes on the bone,
okay,
and then there is a layer of plastic, methyl methacrylate, that goes between the metal parts and has very little friction.
Okay. And so that's what it's replaced with. And
correct,
it's the same with shoulders, hips, knees. I mean, they are obviously different.
There was a brief period when we did metal on metal hips.
Okay.
And they work very, very well, but there's some concern about whether they cause problems with increased metal ions in your blood.
Huh.
My personal opinion is that they don't, but right now across the field there's such concern that we don't do them anymore.
Okay. How long have you been doing this?
About 25 years.
So has it changed? I mean, has
Totally.
Material changed,
yes,
the procedure changed?
Yes, for a while there was a big move to use titanium instead of the old stainless steel, but it was discovered that increased titanium ions in your blood is probably not very good for your health.
Okay.
It depresses your immunity.
Oh, okay.
So now we don't use titanium very much anymore.
Okay. And then the surgery process, has that changed as well? I think about, how having babies has changed. You used to be in the hospital for a week.
There was a big move 15 years ago or so for minimally invasive surgery, but it was really just the same operation through a smaller incision.
Okay.
I think we all made the incisions a lot bigger than they had to be. Now we've been trained to make the incisions smaller, but again, truly minimally invasive surgery is not done very much anymore because there was a big increase in malposition of components as people tried to do it through a small incision, and the incision wasn't quite big enough. They always say, at least in training to people, they heal from side to side and not from end to end.
Gotcha.
So better to see what you're doing than have a little bitty incision. Right.
Gotcha. And is a joint replacement kind of the last resort for wear and tear because you have to, do surgery and make an incision, and there's...
It is. The reason I would tell you if you were my patient is because the joint's not going to last forever. Okay. And when you do it, then the clock starts ticking. The success rate for revision surgery, while it's very good, is not quite as good as primary
the original
surgery.
One. Okay.
Right.
About how long do they last?
We usually tell people 20 years, and actually the newer ones may last longer, but I haven't been doing it long enough to see them more than 20 years or so, right?
Okay. So somebody comes to you and they have, either because of work or hobbies or something like that, they have knee pain. It's their first visit to you. How does that process go?
Well, first I would take their history and then read it. Then I'd go in to see them. I'd probably examine their joint. Okay. And I would definitely want to look at an x-ray.
Okay. And is an x-ray good? Is a CAT scan or MRI?
It's possible to diagnose things without x-rays, but since I'm an orthopedic surgeon and I'm the sort of the court of last resort, I always want to have an x-ray of anything I'm looking at.
To make sure. What they say, okay.
Right.
Now, do you recommend things like, say this person is a little bit younger, and so if they had something replaced, 20 years might not last them as long as somebody else. What other kinds of things do you recommend in the meantime before?
Well, of course, you can modify your activities. If there's something specific that you're doing that's causing your symptoms, you can inject the joints and sometimes get great relief with just a cortisone injection, judiciously used, or there's something called viscosupplementation that is a chemical remake of the fluid that's normally in a joint. Okay. And for reasons that aren't completely understood, when we inject that in a joint, a lot of times that gets rid of the pain for 6 months or a year. Okay. That's so reproducible that Medicare even pays for it automatically without having it approved, which is not very common.
No, it's not. That's saying something.
Yes. We can do that. We can fix you with a brace that will unload the part of the joint that's wearing. I haven't found that those are terribly effective, but some people they help quite a bit. Physical therapy to strengthen the muscles around the joint will sometimes give you great relief. And if you've done all those things, even had an arthroscopy where we just look in your joint and make sure the cartilage is not too terribly worn and take off the rough edges and that sort of thing. If you've had all that done and you still have symptoms, then you're a candidate for a joint replacement.
Okay. So arthroscopy, that's another thing that I hear that people have had. Is that that's a surgery where you're in the OR, but it's kind of exploratory?
It's very minimally invasive. Okay. And we just look at the joint, and there's some things we can do, little rough edges we can take off. We can fix little torn meniscus, the little shock absorbers in your
I've heard that.
Yeah, so I do a lot more arthroscopies than I do total joints, but
because you want to make sure you've done everything.
Exactly, and a lot of times people get several years of relief from having an arthroscopy.
Okay. When you're saying all this, there's, when I think of a knee or a hip or shoulder, I just think of the bones. But there's the muscles around it, tendons, ligaments.
The cartilage, the little shock absorber menisci are mainly in your knee, but they're in other joints too. Okay. Your hip, your shoulder.
So all of that can malfunction in some way?
It can. It can all be torn or injured and fixed.
And then require, might need a replacement at some point. So if somebody comes in, you look at their history, because some of these things have a little bit of a genetic component to them. And I've talked to other people from therapy or pain management, and they talk about how some people may have, no little shock absorbers left at all, but they have a higher pain tolerance. Does that?
It's absolutely true. Some people will have an x-ray that shows very significant degenerative change and no symptoms. And then I wouldn't do anything. Some people have normal looking x-rays and terrible symptoms. And for them, we look into it and see if we can find something else.
So it's all based on how it's impacting your day-to-day functioning,
Exactly.
how your pain is, all that kind of stuff.
And all the x-rays and all just give us more information. But what really matters is how you're doing.
At what point would somebody come see you or Dr. Kresge or an orthopedic surgeon? I mean, is it when they just can't take it anymore, or can they come see you when they're like, I'm getting some knee pain?
No, they can come see us when they're just having symptoms. Most people go to their primary care physician and then are referred in. But
Okay.
some people just call and make an appointment, and that's okay too.
Okay. And I suppose this is a whole other show, but the insurance, you talked about the one kind of injection that Medicare covers. Do they go through the calling the insurance and all that kind of stuff for all that?
Every insurance plan is different. But what I meant to say about Medicare is that they'll automatically pay for those injections without even having them approved,
Okay.
which is really unusual.
That is very unusual. So that's part of the process too, is because I'm sure they want to see that you've tried other things before going to the...
Some insurance companies go so far as to take a patient who comes in and I feel they need an MRI or even a surgery, and they will deny it and say they have to do XYZ first, which doesn't really make sense.
No.
But they're paying the bill, so you have to do what they say.
They are. And I often, in many topics we've talked about on this show, I think about how, you've been doing this for a while, you would think this would be the next step, but okay, we'll do this.
Well,
this,
that's
and
one of the
this.
reasons why it's probably better to go through the primary care physician first, because then they take care of all that stuff before you get to us, and we don't have to go back.
Go back and try things first.
Send you to physical therapy for 6 weeks. And
wait and
give
see
you
how
an
that does.
injection and
Okay.
et cetera.
All right.
Right.
Okay. We're going to take a quick break, and we'll be right back. Dr. Goings talking about joint replacements, and talked a little bit about the difference between a joint replacement and some of the other exploratory repair kinds of things that you do. But sometimes after wear and tear, injury, trying lots of other things, joints need to be replaced.
That's correct.
And they last about 15 or 20 years?
20 or so is the goal.
Okay. So that's a pretty long amount of time.
Mm-hmm.
So is everyone a candidate for joint replacement surgery?
I think so, yes.
Okay.
Unless you're allergic to the things that they're made out of,
Okay.
which is cobalt and chromium.
Okay.
There are some people who are allergic to chrome.
Do they test for that before?
No, you usually just come in
You
and
wouldn't
say,
know.
my ring made a rash around my finger or something.
Then
that
you
they're
know.
allergic.
Okay. But age isn't necessarily.
I've done them on teenagers on a few occasions, and I've done them in people as old as 92.
Okay. So age doesn't seem to be particularly
No.
of an issue. Other things might, if you have a heart condition or you're not a candidate for any kind of surgery.
Right, if you can't be cleared for a major surgery, then you can't have a joint replacement.
Okay. For whatever other conditions.
Usually cardiac or pulmonary.
Okay. But that's not age or anything like that related?
No, it's just your personal health.
Okay.
I remember too, I had a lady once who was 104 that had a hip replacement for a fracture.
Wow.
She, I think, is my oldest hip replacement patient.
Wow. Yep, I would say age is not a factor.
Well, she didn't have any choice because it was broken.
It was broken. And teenagers too, you said, that's not ideal.
Not
You
at all
really...
ideal. That's a serious problem. But sometimes a child has juvenile rheumatoid arthritis and their joint's just worn out, or if they have an accident and fracture their joint.
Okay.
There are some degenerative conditions of the hip that children have that cause them to wear out in their 20s.
Gotcha. And so they've tried all the other things and they...
Right.
Okay. So I guess I will ask that question is, and you mentioned it in the beginning, if a person has to have it replaced twice, what's that like?
Well, for them it's not a lot different. they have the same pre-op and post-op care.
Because it's been 20 years,
the
so
same
things
recovery,
have healed. And
but the surgery's a little more difficult because the bones are altered and
okay.
things are worn, but it's not that hard.
Okay, so it is possible, but not ideal.
I've even revised them a second time.
Oh.
But, that's not what I did the primary care, but somebody years ago did it.
Right, okay. Right. So it is possible.
It is possible.
So they have the surgery, and this is in the OR where they're under anesthesia, obviously.
Yes.
They're out cold and are, okay. And then what happens after that? Do they spend the night in the hospital? Are they there for a few days usually?
The classic person who has a total hip or a total knee replaced or shoulder is in the hospital for 3 nights.
Okay.
Now there's been some move in recent years to get them there less. There's some people who even do outpatient total joints, believe it or not, in big medical centers, but here it's usually 3 nights.
Okay.
So if you had surgery today, you'd go home on Saturday, today being Wednesday.
Okay. So it's not, because it's not just the joint. You had surgery. You have an incision. You
had a general anesthetic for probably an hour and a half or so. You may have lost blood, and you usually keep bleeding for a while after surgery.
Sure.
A lot of times on the second day, people will get to where they need a transfusion.
Okay.
But a lot of times they don't, and there's no way to know that without having them in the hospital, in my opinion.
Yeah, you don't want to be home and
need a transfusion.
I need a transfusion. No. It's not real convenient.
You could also have a post-op fever elevation, and we need to keep you around to make sure you didn't have an infection.
Okay. So there's a lot of things to keep an eye on besides just the joint that was replaced.
Right. Usually an infection from surgery, even if we intentionally put germs in your incision, which is ridiculous, but it would take 3 days for you to show signs of an infection.
Okay.
So the third morning, if you're afebrile and your blood levels are okay, you're safe to go home.
Okay. But you need to be kept an eye on at least for a couple of days.
I think so.
Now, therapy. Mm-hmm. They always, therapy's always in there, whipping you back into shape. How, is a person non-weight bearing or you can't move it?
I always let people bear full weight, but different people have different notions.
Tolerances for it.
I also usually don't cement the prosthesis in. The old-fashioned way to do it is to cement it. A lot of people still do. I do sometimes, but usually I just press fit. So it's specially made so that the metal exactly matches the bone, and you just hammer it in and you don't have to put cement in. The cementing process is sometimes associated with serious medical complication. Okay. It causes your blood pressure to drop to nothing temporarily.
Okay, good.
But I don't want to do that.
Right.
So that's one of the reasons I don't cement. Although many people cement. Dr. Kresge cements them all, and his patients don't have that problem.
They don't have that problem.
They do okay. Yeah.
Okay. So, but therapy can start that day?
Therapy can start pre-op, actually. Mm-hmm. If you have a joint contracture or you have weak muscles from your joint being bad for years. Okay. Most people who have arthritis so severely that they need a joint have a lot more pain than they think they do. That sounds crazy, but because it happens so long of a time and so slowly that they don't notice.
Right. They're just
and then they wake up from surgery and say, hey, it doesn't hurt anymore. Yeah.
Okay.
So, anyway, preoperative physical therapy is helpful to get your joint moving and to get you stronger. It's not absolutely necessary at all, certainly. Postoperative PT, I think, is a real good idea. Gets you walking and, again, gets you strong. But every once in a while, there's someone who just won't go.
Yeah. I've had different therapists on in the past, and that's the double-edged sword with therapy is you need to do it so that you feel better, but you don't feel like doing it. But if you don't, then it's worse.
Right. So you usually start therapy the same day as your surgery in the hospital. They come and see you that afternoon, and they do it every day. And then when you go home, you have 3 choices. You can either come back to the hospital, which is good because they have all the equipment there that they can't take with them.
Right.
You can do home PT too, and that's good if you can't get out or something, but they can't bring all the equipment in, so it's not quite as good of an experience.
Okay, so they can have therapy after that.
Right.
Does a person get back to their normal function? I don't know, whatever their normal is, I suppose.
I would say that you never get 100% back to someone who's not had a surgery, but you can certainly get close. There have been professional athletes who played professional baseball, for instance. Bo Jackson played pro baseball for 2 years with a hip replacement. Of course, what they don't tell you is he's had it supervised twice now already. But it is possible to have a high level of function with one end.
Okay. But that probably involves a lot of therapy and a lot of gritting your teeth. And
lots of work, yes.
Okay. So, and again, it's a matter of just like the pain that brings them in to have a surgery has a lot to do with it, but their, the therapy that they do afterwards and the effort that they put into the healing. So when they do therapy afterwards, they're not, running up and down the stairs if it was a knee or a hip. They're just kind of gently moving. Can they move it?
The first goal is to get your range of motion back.
Okay.
And then working on strength of the muscles.
I also had somebody in here talking about hand therapy, and she said when somebody has like a hand or wrist injury, that therapy sometimes also needs to work to make sure, because when you have that, you're like, this for 6 or 8 weeks or whatever, to move all the other things.
There's a condition called Reflex Sympathetic Dystrophy, which most people have never heard of.
Nope.
But it's not a good thing to get. It's usually where you have a minor injury or a minor surgery on a hand or a finger or something, and your brain tells you, don't move it, don't move it, don't move it. With your upper extremity, it's real easy to just do this and not move it.
Right.
And next thing you know, it's all frozen.
It's all frozen.
And it can be very serious.
Worse pain than the original.
Right. So physical therapy is a good idea for that.
Okay, so it keeps everything moving. Even things around, like you said, pre-op therapy to make sure it's as strong as possible, your hip or your knee or your shoulder, whatever.
Right. Now with your lower extremity, you have to use it to walk around. But with your upper extremity, you don't.
Right.
So those kind of problems are a lot more common with upper extremity injuries.
Gotcha. Yeah, you have to use your lower ones. You don't have a choice. Okay. So if more than one joint, if you, I don't know, a shoulder and a knee, or a knee and a hip, if somebody's, an athlete or something like that, can you do them, 2 for 1?
I would never recommend doing more than one at the same time.
Okay.
I've been involved in doing bilateral total hips or bilateral total knees.
And that's when, like, 2 different ones, or if somebody needs both knees done.
Correct, but I wouldn't recommend doing it. If you have an upper extremity, it's better to get the upper extremity fixed first, because usually after you have a total hip or knee, you have to use a walker. You can't use it with a bad shoulder.
Gotcha. So is that just kind of the rule of thumb, or is it completely dependent on the person's
It totally depends
case?
on the person and what's bothering them the most.
Okay. What do they use the most, bothering them the most?
Extremely common is a bad disc in your neck and a bad shoulder, in which case we always recommend doing the neck first, because if you still have a problem with the nerve, you can't do the rehab for your shoulder.
For your shoulder.
Yeah.
And that's why they come to you. We don't have to know that.
Right.
Okay. And you do that just by, talking to them about what do you do on a daily basis,
and
what's your
examining
pain.
them and seeing what kind of pain they have, what their studies look like.
And then I'm sure you do a lot of education about, okay, here's the reality of it. This this is how much therapy you're going to need. This is kind of the pain that you're going to be dealing with. Typically, you want to do the neck before the shoulder, or the shoulder before the knee. Just educating them.
Right.
Have you ever taken anybody completely by surprise and they say, "Oh, forget it, I don't want this"? Probably not. By the time they get there, they're in so much pain.
Yes. It's not real common for somebody to change their mind and chicken out, but it happens every once in a while. Rule of thumb is you should never have a surgery like a joint replacement unless you really want to. So even if you have all the indications and you just don't want to, you shouldn't. Because if something goes wrong, what are you going to say?
Yeah, I knew I shouldn't have done it. Okay. Right. Any last thoughts? Any final things you wish people knew about joint replacements, or?
I would just say here, we can do them and we can do a fine job. We've done a lot, and you don't have to go off to the big city to have your joint done, because it's a very common thing that we do. I've been doing them for 25 years. Dr. Kresge's been doing them for longer than that.
Right.
Yes.
You've seen a few joints replaced. That's good.
So
wear and tear, maybe see your primary care physician first, come in to see you.
I would suggest if you have pain in an area of your body, you go see your primary care doctor, and they can decide whether to take x-rays, examine you, and if you need to see us, they'll send you right along.
Okay, and then you send that information back to the primary care physician as well?
Absolutely.
They kind of manage them, all the other medical stuff while they're in the hospital?
Nowadays we are in fact all on the same computer system.
Right.
So as soon as I make my note, which is as soon as I see the patient, they can see it.
Your family doctor can see it?
Absolutely. And I can see all their notes when the patient walks in the door.
Awesome. Thank you very much.
You're welcome.
All right, we're going to take another break and we'll be right back. to thank Dr. Goings for being our guest today, talking about joint replacements, but also talking about all that other stuff in your muscles and your tendons and your bones and all that kind of stuff. There's a lot going on in there, so if you have questions, obviously talk to your doctor, make an appointment to see Dr. Goings or Dr. Kresge. Their office number is 419-732-8837. Great information about what happens before, during, and after a joint replacement. So very, very helpful. If you ever have feedback about a program or a suggestion for a future episode, please let us know by sending a note to Time for Health, 615 Fulton Street, Port Clinton, Ohio, 43452. Or you can email Carla Pelz at the high school, cpelz@pccsd-k12.net. So think about all the stuff we talked about today, whether it's something that is of interest to you or maybe somebody you know and love, share the information. And until we meet again, I encourage you to make time for health.